أعوذ بالله السميع العليم من الشيطان الرجيم بسم الله الرحمن الرحيم. Just wanted to start by thanking SBMAA for giving us this platform for enhancing our knowledge. And this would have not been there if there was no guidance from our beloved Mawla, Sayyidina Mawlana Abu Ja'far Sadiq Ali Qadar Mufaddal Saifuddin, Tawalla Amru Sharif ila Yawmiddin. And just wanted to do dua that इन्हीं उमर शरीफ ने तार रोज़ क़यामत दराज and दराज करें. With that, I also want to thank Murtaza Bhai Khambati, who is a medical student in Virginia College of Medicine, as well as he's a second-year medical student, and Burhanuddin Bhai Sabir, who is a first-year medical student in Albany College of Medicine. With that in mind, let's start with our presentation today. And we want to talk about asthma. How we're going to go about it is we're going to present some cases, and then we're going to dissect that case, and we'll overview the treatments of how we went through the case, and we'll take some questions and answers after that. So this is the first case. 75-year-old woman with a history of asthma since childhood. She used to be well controlled with inhalers. She was a preschool teacher. She's quit about 5 years, so 5 to 10 years ago. She used to get about 1 to 2 exacerbations per year, but lately, for the past 2 years, she's gotten progressively worse, and her exacerbations are 4 to 5 times per year. She has daily symptoms, and she is using a rescue inhaler at least 4 to 5 times per week. So this is the case, and the question becomes is how do we go about this case? So what is asthma? At this day and age, where medicine has come such a long way, to define asthma as a single entity is obsolete. Asthma is actually an umbrella term. It can be divided into multiple categories, and it depends on different ages of onset, different severities, different responses to medications. There's different triggers. Next slide. And one way, researchers and scientists have come a long way in figuring out how to define asthma in different phenotypes or endotypes, but there is no consensus to it. What I do in my practice is to figure out what is the pathway the patient is taking in making the asthma worse. So if you look at this slide, you can see that there are triggers, and there could be different triggers. There could be allergies, viruses, bacteria, and remember that other one as well, which is NSAIDs like aspirin or NSAIDs with nasal polyps and history of asthma can trigger asthma as well. Traditionally, we know asthma as allergic eosinophilic, which is the middle pathway. But as we know more and more about asthma, there are other ways that leads to inflammation of the airway, and that's the non-eosinophilic asthma, which leads to, next slide, a lot of inflammation and remodeling. So if you look at this slide, in acute response, we know asthma as a reversible condition. In younger, when we were young, and if you had asthma as a child, that asthma is usually reversible because it's an acute response to an allergic reaction. But as you grow older and it becomes a non-eosinophilic asthma, then you get into chronic inflammation where your airways become more and more inflamed. You get chronic bronchoconstriction, you get chronic mucus production, which can lead to airway remodeling, which leads to future of chronic shortness of breath and hypoxemia. So going back to our case, we had a case of a patient who has history of childhood asthma, and she was well controlled when she was young. As I said, she was in the acute phase of it, and she went in and out, and she was controlled with her inhalers. But as she got older, the inflammation probably turned into non-eosinophilic and it went into remodeling phase. And that's why she gets more exacerbations right now. And she has an occupation that triggers her with recurrent exacerbation. Every time you get an exacerbation, especially in asthma or even in COPD, the issue is that the airways don't come back to the same place that they were before. And as you grow older, when the exacerbations are worsening, the problem becomes remodeling. So how did we go about in figuring out what's going on with this lady? So what we did is we got some blood work. We got her sputum to look for what kind of cells are in there. We got pulmonary function test, and we checked for fractional excretion of nitric oxide. Next slide. So if you look over here, what you see is a pulmonary function test. In this, what we're looking for is obstructive disease. And how is obstruction measured on pulmonary function test? What we're looking at is the ratio between the amount of air you can blow out in 1 second, which is FEV1, divided by the FVC, which is the forced vital capacity. And in her case, that ratio is less than 0.7, which is consistent with obstructive disease. In her case, it was 63.96. How do we know what the severity of the disease is? And that you know by looking at the FEV1, which is the forced expiratory volume in 1 second. And the degree is measured by what the FEV1 is. Mild is more than 80%. Moderate is between 60 and 80. Severe is between 30 and 60, and very severe is less than 30%. In her case, her FEV1 prior to bronchodilator is 50%, consistent with severe obstructive disease. And after bronchodilator, it goes up to 56%, and percent change is about 13%. And how do we know there is a bronchodilatal response? Is you have to look at the percent change in FEV1 and FVC. If it's more than 10% change, then you consider as a positive bronchodilatal response. In her case, her FEV1 percentage went up by 13%, and her FVC went up by 14%, that she has positive bronchodilatal response. And the other thing we look for is air trapping. And in her case, when we're looking at her lung volume, you see that her lung volumes are elevated. And if you look at a residual volume, which is the RV, and the ratio of RV over TLC shows it's 165% and 160% consistent with air trapping. The good thing in her case was that her DLCO was still normal, which tells me that her ability to get oxygen from the lungs into our bloodstream is intact still. Next line. We looked at her blood count. What we're looking for is eosinophil counts and IgE levels. In her case, we see her eosinophil count is 605. Her monocytes are elevated as well. So I'm assuming that there is neutrophilic response with her eosinophils as well. Her IgE levels were 189 as well. And we also looked for allergen panel on her too. And her allergen panel was positive for multiple allergies to multiple trees and weeds and stuff like that too. So, and then we looked for FeNO. What is FeNO actually? So fractional excretion of nitric oxide is actually derived from inducible nitric oxide synthase. So what that enzyme does is when you have an eosinophilic response to your airways, it has to be eosinophilic response. The only way you get elevated nitric oxide is you get you have this triggers activate these nitric oxide synthase, which leads to nitric oxide production. And that leads to exhaled nitric oxide. And that's what we can measure to see if patient has eosinophilic asthma or not. And the number usually we look for is more than 50 parts per billion. You can go up to 20, above 20, people say, like, the researchers have said that, yes, there is an eosinophilic response, but above 50, the specificity is extremely high that it is an eosinophilic response. Do we get false positives? Yes, with nitric oxide, especially if somebody has rhinosinusitis, somebody has human rhinovirus, somebody has eating a lot of nitrates. Those people produce more nitric oxide, and that you could have false positives from that. Does it correlate with severity or that it tells you that you're going to exacerbate more? No, it just tells you that you have an eosinophilic response to the triggers. And in her case, her FeNO was 150. So let's get back to her case and figure out what her accurate diagnosis is. So if I'm talking to another pulmonologist or I'm talking to another physician who deals with asthma, I'm going to tell them that this lady is asthmatic, but I'm not just going to say she has asthma. I'm going to tell them that she has uncontrolled, severe, persistent, eosinophilic, and with probable neutrophilic component asthma. And it's worsened with her age as well. Next slide. So now I want to introduce you to Murtaza Bhai Kambati, who is going to get us through how do we treat asthma and what are the new GINA guidelines and what are the new treatments in asthma.
Salam, Kim Shasagla. Thank you so much, Dr. Kadir. So yeah, I will go ahead and talk briefly about latest insights on inhale treatments for asthma and COPD. So here we are focusing on specific types of like the advantages and disadvantages, as well as like the types of inhaler. So firstly, we categorize these inhalers into short-acting bronchodilators, and which are also known as the rescue inhalers, and which open the airways and provide like a quick relief for sudden attacks. We also long-acting bronchodilators, which are used for over a longer period of time, and inhaled corticosteroids, which are integral to reducing inflammation, and they are also taken to prevent asthma attacks. And lastly, we have a combination of the combination inhalers, which are used for multiple medications. Now, one of the things interesting about the combination inhalers is that it's convenience, right? So it is having one device for both maintenance and relief medication, and can be a significant compliance advantage for the patients. Meter dose versus powder inhalers. So meter dose inhalers require coordination between the actuation and inhalation, while the dry powder inhalers are breath activated. And this difference is crucial in the patient education and in determining which patients are suitable for each type of device, especially in those with dexterity or cognitive impairments. We also have soft mist inhalers, which are newer type of inhalers that spray a dose of medicine when you press on it. And those inhalers can deliver medication more effectively to the lungs compared to the traditional meter dose inhalers, and especially in those patients with poor inhalation techniques. Then we have a nebulizer, and those can deliver high doses of drugs and do not require patient coordination with breathing, and could be used in acute care settings or for the patient with severe exacerbations. However, they're expensive and less portable. They're also really helpful to kids as well. Now, with all these inhalers, there are disadvantages. So it can lead to oral candidiasis, especially with the pressurized meter dose inhaler, or it requires deep and forceful inhalations with the dry powder inhalers, which may not be suitable for all the patients. Then this slide, it talks about the newer asthma guidelines according to the GINA, which includes that all the asthma patients, regardless of their severity, it recommends that inhaled corticosteroids in combination with a long-acting beta agonist should be used as a reliever therapy. Based on asthma severity, this treatment can also be used as a maintenance therapy too, and which ensures that the daily coverage of the inhaled corticosteroids while providing the additional doses of ICS as soon as the symptom appears. And a lot of other studies have mentioned that it actually helps in reduction of 40 to 50% of exacerbation compared to using only inhaled corticosteroids by itself as a preventative treatment and SABA as a separate. Now it shows two tracks. So first track one, it means that it's say that the medication containing both ICS and the LABA as a formoterol is used both daily and as needed for relief. And track two says that so if the patient is not adherent to the schedule, then one can start with the low dose ICS and SABA as per need. Now, according to the newer guidelines, they also say that leukotriene or leukotriene receptor antagonists like montelukast are considered as one of the additional controlled treatment options for asthma, particularly for the step 2 treatment in both adults and adolescents. However, they are less effective and than the low dose inhaled corticosteroids, especially for preventing the exacerbations. And this slide basically indicates different type of treatments and different categories of inhalers and provided like their subcategories. Now, interesting thing to note on this slide is basically that Air Supra, which is when it's a new type of inhaler, and when comparing it to a standard albuterol inhaler, it not only treats asthma symptoms but also prevents asthma attacks, unlike buterol, which only treats the symptoms. This positions Air Supra as a more comprehensive option, potentially improving the management of asthma control in patients. Now, besides the inhalers, so we already talked about treatment as inhalers. So beside inhalers, we have another thing known as biologics. So biologics are for asthma. They are a group of medication which are derived from the living organism or their products, and they are specifically designed to target particular components of the immune system that drive the inflammation in asthma. So they basically represent a targeted approach to treatment as opposed to the traditional medication that have broader effects, like a systemic effects on other places. But these biologics target specific pathway and specific interleukins, which helps to reduce that inflammation on that specific cascade. So as we saw earlier, that the asthma exacerbation occurs when exposure to allergens lead to activation of interleukins and T cells. So what biologics do is that they interfere with these pathways by binding to those interleukins and block them to attach to the specific targets. Now, it is really helpful in terms of precision medicine in asthma care. So, by understanding the specific inflammatory pathways and phenotype of asthma, these biologics can be tailored to individual patient profile for better outcomes. This slide basically shows different mechanism of action of the biologics and where specifically it blocks the pathway and further and helps to prevent the further inflammations. Now, we tried inhalers, we tried different biologics. Now, if the patient still having severe symptoms, what is the last resort? So basically, it's a bronchial thermoplasty. Now, bronchial thermoplasty is basically it delivers thermal energy directly targets the airway smooth muscle with the goal of reduction the airway smooth muscle mass. Now, it is a therapeutic intervention for the patient with severe asthma, which is uncontrolled by the inhaled corticosteroids and the LABA. Now, although this technique is very novel, safe, and cost effective in the reduction of exacerbation and hospitalization following treatment, it comes with its own disadvantages as it is invasive and its consequences and adverse effects are severe as well. Do you want to unmute, Dr. Kadir?
So coming back to our case, what we did for her. So what I didn't tell you guys was that she was on Xolair, which is a biologic, initially when she was young. But despite that, her inflammation was getting worse. Her eosinophil count was much more elevated. It was 605. Her severity on her PFT, as you saw, was severe obstructive disease, and she had IgE level of 189 only, but her eosinophil count was more than 500. So if you go back to that biologic slide and look at which one would be the best one for her, would be dupilumab. And that's what we started her on. She was already on Symbicort. She was already on Montelukast, and she was getting Xolair, but we switched her from that to dupilumab every 2 weeks. And we made sure that she was up to date on our routine vaccinations. And for the past couple of years, she has not had any exacerbations. So that was for her. The main things I want you guys to take home with asthma is that it's not a single entity. Um, make sure that you know what the trigger of the asthma is. Make sure you know the severity, what the onset of the asthma is. Is it controlled or uncontrolled? And what pathway do you think is going on in the patient so you can treat the patient in the right manner. So that's the take home point on asthma treatment. So next case I want to get into is this one. There is a 67-year-old woman who came in with intermittent cough, chronic bronchitis. She had 2 to 3 episodes of childhood bronchitis, which she was always told that she had bronchitis. She was given antibiotics and cough syrup, and she would bounce back from that. And she was not on any routine inhalers or anything like that. But in the last few years, she's needing routine inhalers, and her exacerbations are getting more frequent, and she's wheezing and crackling on exam. Her saturations are 92% on room air, and she's got shortness of breath with exacerbation. So as you already know, what we would do with these kind of cases is figure out what the triggers are, what the PFT is showing, what is the pathway that we're looking for. So look at what we got for her. So her spirometry was actually normal. Look at this. Her FEV1 over FVC showed the ratio is 66. So she's got obstructive disease, yes, but it's very mild. Her FEV1 is only 80%. She had no bronchodilatal response, and her chest X-ray was normal. But look at her triggers. Her triggers are showing that she has a IgE to aspergillus of 85.1, which is severely elevated, and her IgE levels are 4,000. So, what should we consider here? And to talk about that, I'm going to introduce you to Burhanuddin Bhai Sabir, who is a first year medical student in Albany Medical College.
Right. Thank you, Dr. Kadir. So we'll go into what's going on here, and we're going to talk about a condition called ABPA. The full form of ABPA is allergic bronchopulmonary aspergillosis. This is an allergic reaction, type 1 hypersensitivity reaction caused by a fungus, which is called Aspergillus fumigatus. And this is commonly seen in 30 to 50-year-olds. It can also be seen in children. More than 4 million people worldwide are affected, and the highest incidence is in the wintertime. It affects patients with asthma, people who have cystic fibrosis, and people who are immunocompromised. And we'll go into more detail about why that is, but why it's so prevalent in these populations. And it's a very important condition because it can have severe complications, such as chronic bronchial inflammation, eosinophilia, airway remodeling, and bronchiectasis. So I also next want to talk about what are the different types of ABPA. So there are 4 different types of ABPA. So the first one is very important to note because it's one that's often missed. So it's called serological ABPA, and this presents with the absence of central bronchiectasis. And because there's an absence of bronchiectasis, it's often missed in the diagnosis. So serological ABPA means that you're going to have elevated IgE levels over 1,000. You'll have an elevated IgE level specific to A. fumigatus, and you'll most likely have a normal CT scan. So you won't see any changes, opacities on your CT. So oftentimes this diagnosis is missed and is thought to be something else. But it's very important to catch this early because if it's treated well, it can prevent its progression into bronchiectasis. And so another thing that's part of diagnosing ABPA-S is a positive skin test to Aspergillus as well. Now, if ABPA-S is not well managed, it can progress, and then you'll develop what's called ABPA with bronchiectasis or ABPA-CB. And this will present with widenings of the airways, increased mucus in your airways, decreased clearance, and this is commonly seen in upper lobes of the lung, and this will show up on the chest X-ray or CT. Next, we have ABPA with cystic fibrosis. So patients who are cystic fibrotic have an abnormal mucociliary clearance of the fungus, which means it'll be more trapped and unable to leave their airways. And as a result, you'll often see this condition in patients who have cystic fibrosis as well. And lastly, the 4th type is ABPA with high attenuation mucus. So you see this as ABPA-CB-HAM because these patients have high attenuation mucus seen on their CT, and also they're presenting with bronchiectasis as well. And so basically their mucus is very hyperdense, and this will confirm that they have bronchiectasis as well. And this will also increase the risk of recurrent relapses because the thicker their mucus is, they're unable to clear the spores. And we'll go into now more detail about exactly how ABPA comes to be. So in this, it's the spores of the fungus that are the major issue. When they're inhaled, they behave as antigens. Now, it's very important to note that this is normally cleared by immunocompetent patients. Why is this? So when we normally have a mucociliary escalator, as it's called, where mucus traps foreign antigens, and then the cilia allows it to be cleared from your airways. However, when you have thick mucus in your airways, airways, then this will make it difficult for you to clear the spores and they will remain trapped. And this is seen in patients who are asthmatic, patients who have cystic fibrosis, and who have a high attenuation mucus. And all these conditions are contributing to thick mucus in your airways. So once the spores colonize your mucus plugs, they have proteases, which release pro-inflammatory cytokines. And these will damage your epithelial cells and disrupt the barriers that are protecting uh, that are protective. And this damage will lead to an immune response, and you'll have an increase in CD4 Th2 cell activation, and specific interleukins are released, IL-4, IL-5, IL-13, and this will increase IgE levels and blood and airway eosinophils. And as we discussed before, the IL-5 interleukin is directly responsible for activating the eosinophils, which is why that's a good marker in ABPA when that level is elevated to consider this as a diagnosis. And this leads to mast cell degranulation. You have an allergic reaction, and that's how it presents as. So how does it present when you see a patient? They're most likely going to have poorly controlled asthma, which means they'll have increased that mucus, more trapping of the spores, and more likelihood to have that reaction to it. Then you'll have characteristics that are specific to bronchiectasis. You'll have fever, hemoptysis, malaise, fatigue, dyspnea. In addition, you'll have productive cough with brownish mucus plugs. They'll probably be wheezing on exam. And as we discussed, you'll have eosinophilia and elevated IgE levels. And specifically, as we saw in the immune of the patient, IgE levels that are specific to Aspergillus fumigatus. You also can do a skin test on them, which is where you inject the Aspergillus antigen into their skin. And if they have antibodies present against the antigen, they'll develop a wheal or edema in response. So you can test for that. And as it leads to bronchiectasis, widening of the airways, this will lead to an obstructive lung disease, and you'll see markers of obstructive disease on your PFTs and your spirometry. This will be increased lung capacities and a decreased FEV1 FVC ratio. Now, when we move on to treating ABPA, it's very important to know the different subtypes of ABPA because that can affect how you want to treat them. The most mainstay way of treating all types of ABPA is through corticosteroids. This will reduce inflammation, reduce obstruction, and will decrease the IgE levels. And for this, prednisone is most commonly used. The current dosing regimen is half milligram per kilo daily for 14 days, followed by half a milligram per kilo every other day, and then you taper it and it's discontinued at 3 months. And as you're using prednisone, you monitor the patient's IgE levels every 1 to 2 months. And the goal is to have at least a 35% reduction and the radiographic opacities to be resolved. Now, if you have exacerbations and are unable to taper the dose of prednisone, then this is usually when antifungal drugs come into play. And this will decrease the fungal load, and you're trying to take away that allergic stimulus that is causing ABPA. And for this, itraconazole and voriconazole are most commonly used. And you'll do a 16-week dose most often of this drug. Another way to reduce inflammation is through anti-IgE therapy. This will prevent the degranulation of mast cells and basophils. So omalizumab will bind to the Fc portion on the IgE antibody, and this will prevent it from binding to its receptor on mast cells and basophils. And when this happens, they will be unable to degranulate. So you'll have a reduced inflammation, and this is very effective in patients who are asthmatic. And lastly, we mentioned patients who have cystic fibrosis. So they have very abnormal mucociliary clearance. And as a result, they're more susceptible to getting different secondary bacterial infections. So it's important to consider starting them on antibiotics as well to prevent a secondary infection, especially in patients who have a high risk of infections, like seen in cystic fibrosis.
So back to our case, I just want to add a couple of points on what Burhanuddin Bhai said, is that the other thing that you need to, if somebody has bronchiectasis with ABPA, airway clearance becomes a big issue. So you need to make sure that the airways are being cleared. So especially in people who have bronchiectasis and cystic fibrosis and stuff like that, You need to make sure patients are on breathing treatments, some therapies to make to get the sputum up. There are a bunch of ways to do that. A cappella, there is vest therapies, there is um, cupping. There's a lot of ways to get mucus up, but that's another thing that you need to consider. Also, as he mentioned, biologics. When I'm assuming that when these ABPAs and papers were written, dupilumab was not even available. But if you look at the pathophysiology of it, it is a Th2 pathway, and your interleukin 4 and 13 goes up, and Dupixent actually blocks those. So if Xolair is not working and the exacerbations are worsening, then you could switch to Dupixent as well, and that might help patient get better. In her case, what we did is we started her on steroids. We completed 3-month course. She's now on maintenance inhaled LABA and ICS. She's on Xolair every week, every couple. We started with every couple of weeks, and now she's on monthly Xolair, and she has not had exacerbations for a while now. But we did not use any antifungal. And antifungal data is iffy. But if patient is getting worse on current treatments, then the idea is to add an antifungal and see if patient is getting better or not. These are the references that we have used, and we are welcoming any questions if there are any. My assumption is I don't think there's any questions. So I think what we'll do is thank you guys. Thank you everyone for letting us get this platform to present about asthma. Thank you, Murtaza Kambati, for helping us get this presentation, making the slides, and so Burhanuddin as well. Thank you for helping us making the slides and presenting as well. Thank you guys very much.
Yeah, thank you so much, Dr. Kadir and SVMA for giving us this opportunity to present.
Yeah. Thank you, Dr. Kadir. It was really nice working with you. Well, inshallah, we work on more things together. And thank you to SBMA for giving us this platform.